Hello, and welcome to the second of Being's webinars for Mental Health Month, where today we'll be exploring the topic of reclaiming our human rights through advocacy. If you haven't met me, my name's Omar, and I'm your MC and host for this amazing series that Being has created for you. I'm coming to you today from the land of the Gadigal people of the Eora Nation, who are the traditional custodian owners of this land. So I pay my respects to elders past, present, and emerging. I'd also like to acknowledge all people with lived experience of mental health issues and affirm the insights, the strengths, and the contributions they make through advocacy to driving change in the mental health system. Also, I want to acknowledge all people from diverse cultures, including the LGBTQIA plus communities, because an inclusive society matters. Our human rights matter, and that's why we're here today, to reclaim those rights. Now, a lot has happened since we launched a week ago, last Thursday. New South Wales has opened up. We've all rushed to the hairdresser. We've got to see some friends. We've had a cup of coffee. These are beautiful, simple, lovely pleasures. But we're also still in that storm called COVID, and we're all navigating it with different sized boats. So I think it's an opportunity just to pat ourselves on the back. You know, in fact, more than a pat on the back, I think we deserve a hug. Don't you think hugs have been in short supply? So let's give ourselves a virtual hug. So if you will, or if you'd like, take your right hand, wrap it around your body, take your left hand, wrap it around your shoulder, and give yourself a big, warm virtual hug and say, it's okay. Everything's going to be okay. Oh, thanks for that. I enjoyed that. Now, if anything does trigger you in content from today's session, please reach out for support, either through a peer support line or a phone line like Lifeline. So it's been a big week. Last Thursday, we had the absolute pleasure of listening to Robin Priest, who gave us some amazing insights on consumers and survivors driving change. And what I really loved about her launch session was two things. Firstly, the fact that she makes, as she puts it, she makes shit fun. She also challenged us to raise our expectations and our actions. So, two things. You know, our theme for this webinar series is reclaiming our rights. And Robin reminded us that actually, in some situations, we might be claiming them for the very first time. The other one is our focus, and our focus is on empowering consumers in the hope that we can inspire change. And Robin challenged us to expect that we will do so. She said, focus on the positive, pick a lane, pick a passion, and take some action. I think that's really, really powerful and beautiful. So we'll be continuing that conversation today through our kind of panel discussion on reclaiming our rights through advocacy. Next week, we'll look at peer work, and the following week, which is I think the 28th, we'll look at consumer research. But today, it's all about exploring advocacy in action. So we all have human rights, but are they upheld in the mental health sector? We'll look at why it's important for consumers to be involved in system reform and how consumers can be part of changing the system. Our three amazing panelists will share some of their own experiences and also give us some tips and pathways for moving forward in advocacy. Now, we would have loved to have brought this to you face-to-face, but COVID lockdown had other ideas. So we are in webinar mode. We can't see you, we can't hear you, and you can't see or hear each other, but we can feel you. Right? We can feel you, and we can engage with you. We want you to engage. So we would love audience questions, either to individual panelists or all of them. Pop them into the live chat on your right-hand side. So please pop them in. Any questions that you would like to make this very, very interactive. So shall we get started? We have a brilliant panel of three to discuss reclaiming our human rights through advocacy. So let me introduce our three panelists. Peter Schmiedgen is Senior Policy Officer, Being Mental Health Consumers. Peter brings an analytical mind, and having spent 8 years working with the New South Wales Ministry of Health, has a solid understanding of the development of policy in public sector. Peter also approaches his work through a strategic and political context. So put your virtual hands together for Peter. Welcome, Peter.
Hello, everyone. Lovely to be here.
Well, we're glad you are. Butch Young is a Farmgate non-clinical counsellor. Born and raised in Maringo, the land is in Butch's blood. He is a butcher by trade, and he's turned to hand to many things, including 20 years service in the rural fire service. So many of you will know that Butch was the on-ground mental health commander at Hanging Rock, Batemans Bay during the Black Summer of 2019-20. Many of you who also know Butch will know that schizophrenia prevented completion of his degree in social work, and he's turned his passion to peer work. So welcome, Butch, and keep that applause going.
Thank you very much, Omar.
Oh, Butch, always a pleasure to work with you, my friend. Anne is a registered nurse and former chair of Being. She spent many years managing mental health services and has experienced serious episodes of depression and suicidality. She realized that the service was not treating her, but treating depression with a formula that failed to acknowledge her as an individual. So she moved to take a role in mental health consumer advocacy, and she's passionate about that and human rights. So please, everyone, welcome Anne. And in fact, all of our panelists. So let's get into this. We have a question, first question for all of the panelists, and we'll start with you, Anne, if we might. And then we'll get on to Butch and Peter. Can you tell us a little bit about your involvement in the consumer survivor advocacy movement and where you see human rights fitting into this space?
Human rights is a real challenge for many people who are consumers of mental health services. We have legal, we have the mental health acts in each of the states, but often, while they're said to be written with human rights and the best interests of consumers in place, they've often been written with very little input from consumers. And in fact, the last iteration of the New South Wales Mental Health Act, which came out, it largely, it actually had more of a carer voice than a consumer voice. And this is something that we have struggled with for a long time. People talking about us, not with us, deciding what is best for us on the basis somehow that we are not capable of speaking up for ourselves, for deciding our own pathways, for being engaged in our own health care and well-being. And so that, impinges on our human rights in many ways. It leads to involuntary admissions. It leads to control of people by a system which is meant to be there to help people recover, but actually often does. And I guess Butch has some real stories to tell about the effects that involuntary hospitalisation has had upon him. I've been fortunate in that my hospitalisation's never been involuntary, but nevertheless, my experience of hospitalisation, despite having been a mental health clinician, taught me that what people were trying to do was treat a thing, not treat a person. So they had a formula for treating depression, which was, involved things like self-esteem training, anger management, assertiveness. Now, everybody who knows me, knows that from my kindergarten teacher on, nobody ever thought I needed assertiveness training, except when I was unwell. So what they were doing was not treating me, the person, they were treating what they saw as what the illness was. So it left me with not able to be treated for what was really going on, but being treated for what other people perceived was my issues and how best they thought I should be treated.
And how did you turn that, before we get on to Butch and Peter, how did you turn that in terms of your involvement in advocacy?
Well, the thing about it was when that after the hospital, I'd never been hospitalised before. So it was, and even though it was a private hospital, I was really surprised at how restrictive things were and how they use this formula without reference to me as a person. And it really started me think about, well, we're not, we're treating formulas, we're not treating people. We say somebody has depression, somebody has schizophrenia, somebody has bipolar disorder, and this is the way they are treated, not Anne has depression, Butch has schizophrenia, somebody else has anxiety, and so I really started to think that we had to find another way to manage this and to speak up for ourselves. And an opportunity came up for me to be employed in the role of consumer coordinator out in what was then Greater Southern Area Health Service, and I applied and got that. And so that was my pathway. I was kind of about a revelation to me that what we'd been doing, what I had been doing as I was trained for years, was actually not beneficial to many people. In fact, most people, I think. So it was, and then it became for me a task to get engaged in getting people to look at consumers from a different perspective and to engage people in their own care, because mostly they knew what was best for them and often were ignored.
Thanks, Anne. It's good to see how those challenging situations has driven you into becoming a positive force in that one. Butch, love to hear kind of your story in terms of your involvement. And we've spoken before a number of times, but yeah, I'd love it if you could share kind of your involvement in consumer survivor advocacy and also your thoughts on how human rights fit into this space, Butch.
I was in the middle of an apprenticeship, which I never completed, and I had grief. I had trauma from a death, more than one death actually, very personal situation, and I was the last person to know that I was unwell. So even the discussions were outside of me with my wellness. I was on holidays at the time in 1988, my first admission, and I didn't even know where I was when I arrived in Kenmore, New South Wales. I didn't even know if I was in a jail cell or not. So the Mental Health Act in itself, I think, wasn't just trauma on myself, it was trauma on my family too, and the effect on my girlfriend at the time. And I lost my apprenticeship, and so a lot gets forgotten in all of this, in that I didn't give me schizophrenia. I didn't even know what the word was. I couldn't spell it until about 3 years ago. It's more that I probably needed some help and someone to talk to. And my vision of help was to lie on a leather couch and be able to talk about things. And that even today, that still hasn't happened. So the intention of the Mental Health Act, to me, is for everybody else apart from the person, to protect them as far as risk. And I didn't see the benefit to me to go into an institution under the Act and not even receive my own mail. My mail back then was posted to my dad, which I found after he passed away, letters that went to him and were addressed to him. So when Anne talked about communication towards the consumer, it was null and void. And still today, I don't think it's changed a whole lot. It's improved a little bit, but it hasn't changed where it could. And my drive then was anger more than anything else, and to run from services. So even though I had 11 admissions, and all of which were 6 months plus, and I had all my treatment was forced and by police escort, I still believe that very first intervention would have made the difference in my wellness coming a lot sooner, regardless of diagnosis. So I fell into this role wanting better days for other people, I suppose, and wanting to project a voice that was important to me. And a lot of what I saw in hospital that didn't happen to me was very effective on me. So I had nightmares and different things, but I also recognised there's some very, very good people that work in services, and I thought there's a lot of people who needed to change and move on too. So the old style of advocacy was very, very, very. It was very hot and cold. It was very, you were having lunch on your own, and it was combative. And I think the newer style for me when I was advocating for those 10, 12 years was really that team approach and being a greater part of the team. And the most imperative part of your team is the person driving the car, and that's the consumer. So that's what matters in all of this for me, is that we remind ourselves that it's their journey, it's their story, and it's their car that they're driving and steering. And I think that still gets neglected. We want to see success stories. We want to see people be able to regather their lives and be driven and all of that. And I think the results can vastly improve. It can't just be about medication, and there's got to be alternatives and greater ideas for what's happening in people's lives.
Yeah, well said, Butch. And you've gone through so many things, and I guess kind of very grateful that you're doing what you're doing now, because I know you're helping so many people. So thanks for sharing that one. Peter, can we bring you in, please?
Yep.
Just to kind of learn a little bit more about how you got involved in advocacy and your take on human rights in this space, Peter.
So first, thank you so much, Anne and Butch. Powerful voices, both of you. Well, I mean, the kind of advocacy that I'm involved in is systemic advocacy, and what that means is that we advocate, or I advocate in my work and in my role at being, for services, policies, and legislation to change. This means that I spend a lot of time at government meetings, but it also means that I spend a lot of time talking as much as possible, really, to other consumers and hearing what's working and what's not working, so that when I go to those kinds of events and meetings, I'm able to take a voice that's educated by consumer experience on the ground. And I mean, in terms of rights, I think the key areas where rights are really an issue, in a sense, they've already been raised by Anne and Butch, which is, those areas where people are subject to involuntary treatment, whether it's on a CTO, a community treatment order, or, in an inpatient unit. These are the areas where there's the greatest risk of consumers' rights not being respected. And I think that's why in terms of mental health advocacy, rights is such an important issue, because effectively people have almost all of their rights, or many of their rights, taken away from them when they're treated involuntarily. And perhaps at the moment, this is a poignant time to be talking about this, because in fact, the population of New South Wales and Australia have been subject to involuntary treatment for other reasons, in fact, or involuntary restrictions. So I kind of feel like maybe this is an opportunity as well for people to reflect on what that might be like, being business as usual for a lot of people living with mental health issues.
Yeah, it's so well said, Peter, and I think it's that catch-22, isn't it? That risk of rights being taken away at the very moment that they are most needed, which is cause for a lot of sadness and a lot of distress, and that becomes a driver. But again, we're looking, I think, with this webinar series to look at what can we do about it. So we want to keep to the Pareto principle, the 80% of the positives, put our energies into that. The problems are immense, and we're going to get into the crux of the issue. And I think you've all sort of touched on the New South Wales Mental Health Act. This is a question for all of you, and it's a biggie. So, all right, we have the state legislation, including the New South Wales Mental Health Act, which is said to uphold individuals' human rights. Now, I'd like to ask each of you in turn: does the legislation uphold human rights? If so, why? And if not, why? And want to look at this from a couple of different perspectives. I think, Anne, we'll start with you with a clinician's perspective. Butch, maybe you could look at it from a forced treatment perspective, and Peter from your reformist perspective. And slice and dice it, and let's get into it. So, Anne, do you want to give us your take on the New South Wales Mental Health Act, and does the legislation uphold human rights? What are your thoughts on this? We'd love to hear from you, Anne.
I think the spirit of the New South Wales Mental Health Act is meant to uphold human rights, and it's meant to give people the opportunity to object, to be heard. But in reality, that's often not what happens. If you speak with people from the Mental Health Review Tribunal, they see their role, and they see the role of the Mental Health Act as one which is meant to uphold the human rights of people with mental illness. But what happens on a day-to-day basis, particularly in involuntary situations, is quite different. We've seen there's been, and I'm talking about public mental health services here because they're the only ones that have involuntary. We have seen since the 90s a growth in risk aversity within mental health facilities. And partly that's due to the media expecting that, that somehow there's a magic cure and that the health system will be able to fix everybody who comes through the door. And partly it's a concern of health professionals about managing the risk of people, particularly people who may be at risk of harm to themselves. And so in the 90s, when I was managing an inpatient unit, the doors were open. People who were voluntary patients went, were able to go to the shop or go to the hospital canteen. People who were involuntary patients went too, but they went under the escort of staff. But they did. They went, and people did not spend their, even involuntary patients in a high dependency did not spend all day in the high dependency unit. They came out and they had their meals with other people, unless they were really, quite at risk, considered to be very highly at risk. And then they would be managed or nursed in the high dependency area. So over time, we've seen that change dramatically. And I know the Butch can certainly attest to this too, that it's become so risk averse that even if you're a voluntary patient in a mental health facility, you can't get out that door. Doors are locked. And some of that is political. It's come from the state government. It's a risk. Because people have been discharged from hospital, or they've gone over the wall or whatever, the fence, and something's happened to them, something unfortunate's happened to them. And so the whole system clamps down and says, we can't have these people going out. They might be at risk. And you have to have a measure of dignity of risk. The problem with that is that when you give somebody a measure of dignity of risk and they actually act, to harm themselves, then the coroner and the newspapers and the family and everybody, come down on the system. So the system's closed in on itself to protect itself, and that seriously has impacted on the rights of individuals, whether they be voluntary or involuntary patients in mental health facilities.
Thanks. You've raised some wonderful points. I love the ideology versus reality. I like to talk about the risk adversity. There's got some questions coming in, so I might come to them after. Can I come to you, Butch, first for your perspective on the New South Wales Mental Health Act? Yeah. So give us your thoughts, please, my friend.
Personally, I think it needs to be removed. I think it needs to go back to the drawing board. I think our modern society and services have outgrown that in comparison to state services. I think we need to look at alternatives as opposed to the Mental Health Act. The Mental Health Act, I understand that there's certain people that are at risk, and we already have legislation to look after those people. The problematic thing that I see in all of this is that all people get put in the same box regardless of their behaviours, and it should be looked at as opposed to their current behaviour, not necessarily their historical behaviour. The Mental Health Act is very presumptive that all people with mental illness then up in the facility are at risk, which is simply not the case. People volunteer, they come for help. They're scheduled within 48 hours quite often when they're volunteered. And the inconsistency in the people that are calling the shots and their interpretation of the Act is really, really grey. So it does depend on the doctor you get, depends on the nurse you get, the rapport and the trust and how well they know you. So I would debate whether the Act itself needs to be broomed, and we have a really healthy discussion, inclusive of community that don't have mental illness and don't have any regard for it, because the vast majority of people would not even know what actually happens in an inpatient unit. We're talking about a low percentage of people right across our population, but the effect on those people actually affects employers. It affects our community, our tax system, everything. The costing in mental health to enable these things to happen and continue far outweigh the medicine to fix it. I think we need a fix here. I think we need a healthy discussion with our corrective services right across the board, our community members, and people to really have a microscope on what really happens on a day-to-day situation. When I was advocating on the inpatient unit particularly, and I was going into tribunals, I would debate there might be 1% of people to get discharged that day. So they have rights, yes, on paper, and they can argue the point they want to go home. But I would almost think that's null and void now. What is the point in putting someone through so much trauma in their family with the prospect of wanting to go home when you know as an advocate and you've got a solicitor there who's paid to bat for them, the likelihood of them going home that day is very, very small.
Yeah.
So
Which,
objectively, we've got intention for rights for individuals. I don't think the intention's ever been for the individual that is suffering. I think it's for the community members, their family and friends that don't understand what it's like to have a mental illness in the first place.
Yeah, well said, well said. And I think look, this is what these forums are all about, coming up with these big ideas and then talking them through. And I love the fact that you're talking about including the community and bringing the greater population involved and educated on these issues. Let me just go to you, Peter, on this topic, and then we do actually have a question that's sort of on the point of what Butch has said. Peter, your thoughts as from your reformist and systemic perspective. What do you?
I mean, I suppose just segueing off what Butch said initially, I think that's the thing about legal rights. Legal rights are only as strong as the people you have to argue for you.
Yeah.
Really, and I think also it's especially true if you're, for people in inpatient units, you're not really very conscious often. You're often quite drugged, and often not enough time is even taken to really make sure that people understand what rights are and what that might mean in that situation. So that's my first sort of sense of this. But then another thought I had is that, if we really want to kind of take seriously the kinds of UN conventions that we've signed, and in particular here I think of the UN Convention on the Rights of People with Disabilities, we should really be testing our state mental health acts against them. And I mean, the interesting question in relation to the Convention on the Rights of People with Disabilities is that it really radically conflicts with the notion that people are subject to involuntary treatment. There's kind of a big space for debate there, and it often feels to me, I think, that we sign up for these kinds of human rights commitments at a federal level, and it's quite a sort of box ticking exercise. If we took that seriously, we'd be sitting down in each of the states and having a really big discussion about what the legislation looks like now. And I mean, what Anne raised before about dignity of risk is really important as well, because I think the more freedom people have taken away from them at every time they enter an inpatient setting, the harder it is for them to recover. That's my general feeling.
Yeah, thanks, Peter. And another segue, actually, a question from David. Let me just pop this in because this sort of continues the conversation. David says, the Charter of Aged Care Rights allows for people to have a person of my choice, including an advocate, to support me or speak on my behalf. Will the mental health system be looking at the same in any state? One of you, do you want to pick it up just for a short answer?
It already does. It does. You have that right. You've had that right for a long time. Practice is a different thing. Right, whether you've got access to to a person to speak on your behalf is not the same. It certainly says that in the legal documents and the policy documents of New South Wales Health. On one of the points that Peter made about people speaking for you. A lot of the experience of people going before the Mental Health Review Tribunal, they have legal aid solicitors who arrive 10 minutes before the hearing, very rarely read all the documents, have no understanding or concept of mental health or mental illness, treat it like it's an adversarial court process, don't understand where the person is coming from, and very rarely are able to give a good account of that person's needs and requirements and requests at the tribunal. Would you agree with that, Butch?
Oh, what? Yeah, I was just deep in thought about advocacy to take you back there, and if there's a chance of having an alternative to a Mental Health Act, it needs to be an advocacy model, definitely, where the voice is heard. The problem we've had the last few years with our New South Wales peer workforce is that predominantly they started as an advocacy model, a human rights model, and the peer workforce has obviously grown. So they've been factioned out to do other roles, and advocacy is one thing that's been neglected in all this, and it needs to improve. But even back then, it needed to grow, and to think that you have one consumer advocate in an inpatient unit if you're lucky, and a lot of these people are part-time, it's got to grow to the point where you've got that access advocacy 24/7 at home, in community, and all the rest of it. And that doesn't necessarily mean they have to have a lived experience. It means, if I look at my story and my growth and how I got well, it was about people, regardless of the Mental Health Act. My forgiveness, my growth, my self-wellness was about particular human beings that came into my life. And that's what gets missed in all this, because it does matter who's helping you. It does matter who's supporting you, who you're enabled to be your friend and have access to, and all these other things. So people themselves, regardless of their certification, make all the difference in someone's wellness and their journey. And to block access to that's ludicrous. I mean, we brought in a policy of smart technology and mobile phones, and that to me made so much sense, because the number one thing that gets us unwell is communication. The number one thing that gets us well is communication. And this the Mental Health Act discommunicates people.
Does. So there's a lot of great topics here. We've got one more question. I know we're running slightly over time, but I'll pop that in because this is just so interesting. To recap, I think, Anne, you were talking about the documentation is there, but the implementation perhaps not. And that, again, speaks to advocacy as such an important force. And also in terms of legal services, what is it we would like to see from them, as opposed to the fact that they rock up, not prepared. So those are good questions to pursue. Got a quick one for a short answer from one of you. Question from Nicola. Says, with the Mental Health Act, there is such restrictions and lack of input. If this was physical health, would this be the same? Can we just grab one of you to give us a short, sharp 45-second answer on this one, and then we'll move on to lots of other interesting questions. But thank you, Nicola.
Well, I'll say something.
Go on, Peter. Go on.
I suppose my sense would be probably not, because, except in situations, like we have now where you've got infectious diseases, for example, there aren't many areas in other areas of health, physical health, I'd say more generally, where people are subject to involuntary treatment. So, generally you would assume that there would be either consultation, or the reality would be that, in fact, what was likely to be in the legislation wouldn't be likely to take significant freedoms away from people. So I think I kind of see it as one of the things that's characteristic of the Mental Health Acts is that they do take away people's freedoms in a way that other health services don't, and other health legislation doesn't, except, as I've mentioned before, things like to do with infectious diseases like COVID. Yep.
Great conversation. I feel like we could talk about the Act for another multiple hours, but let's keep it rolling, because we have an hour. Butch, I want to come to you, if I may, please. With a question for you, but then Peter and sort of chime in as you wish, because I just love the interaction that's happening. Butch, what do you believe needs to change in the mental health and broader social services landscape for people to feel safe and supported during their stays in mental health facilities?
I'd say access to communication first and foremost, and how that looks. I mean, you're so afraid once you've had an admission or two to be honest about where you're at, honest about how you're feeling, and if you've got a history like me, you don't tend to share. So that's something that needs to change, is the communication. The other part that needs to change is the interpretation of your family and friends, and the support that's put in place for them needs to change. Because if there's only one action that can be taken, that's the only action we can take. And when I said earlier we should broom things, I mean more or less not get rid of them, but clean them out a bit, modernize a bit, and take consideration for people and their trauma. I mean, for me, the risk increased because of the treatment I had. And prior to that, I don't think I was at great risk of harming myself or anyone else. But the way in which I was treated most certainly increased the risk. So it's knowing yourself well enough. If things go wrong in your life, and this can happen to anyone, and it's just playing consideration to have prevention as opposed to picking people up when they're broken. And there's not a lot of services to date that are out there doing this this tender, which is to keep people out of services and out of hospital.
I love the way you're putting some powerful and sensible themes here. Communications being one, family and friends being another. Just getting drawn into this conversation is so good. Can I probe just a little bit more just on communications, Butch? What would you like to see? What does good look like?
I'd love to see nurses love their job. I'd love to see nurses be able to turn up in jeans and t-shirts and actually be doing outreach in your house, as opposed to in a jail setting or a lock-up setting. I'd love us to be an open enough community and society to embrace that when you go to university and you study and you want to work in mental health, that it makes you tick every day and there's energy and you feel like dancing, because the trauma I'm seeing in amongst medical staff is not much dissimilar to the patient. They don't want these things to happen. And quite often they can't speak out because it's legislated and it's an act. They have a dream in university when they come as new grads and social workers and psychologists, and they think, I thought I was going to be doing this. And I want that magic to happen for all of us, and that's for family and our children. And I'm thinking future. I'm thinking about our children, our grandchildren, our neighbours, that we are not just number one in health, that we're the health service that the entire universe wants, because it works, it's effective, it's modern, and it's embracing. And no man, and particularly men with our suicide rate, should ever be afraid to speak out and say, you know what, I'm crook. You know what, I need some help. And if we can create this and be part of this futuristic mental health system that embraces all people. And there's no time like right now with COVID. There's no time like right now with the bushfires. This is our opportunity. There's money there, and it's a conversation that needs to start and be broad and healthy for all of us.
I love what you're saying. And again, this aspirational stuff is so good. And there's a quote, I think, from Leo Burnett, the advertising guy from the 60s and 70s, 80s. He says, if we reach for the stars, we may not reach one, but we won't end up with a fistful of dirt either. So keep aspiring. Peter, let me come to you, please. And maybe this is a question for you, and maybe from the being perspective as well. The question to you, Peter, my friend, is many people inform us that they feel like their mental health issues take priority over the individual. So how do you believe systems and services need to change to be more focused on individuals and recognize the impacts of trauma?
Yep. Well, I'm first going to respond just very, very quickly to Butch. It's a gloss. I kind of think that's, that what needs to change more generally in systems is people's stories need to be heard, so that they're seen as humans, not just as diagnoses. That would be one thing, I think. But now that I just couldn't restrain myself from saying that. But the issue of trauma is also such an important issue. And I think in particular, the things that I think would be could be done in that area to really improve services would be, to provide more training, to people in emergency services and in EDs. And I think I'd think of, ambulance people, ED department workers, and even police on, the possible impact of their responses to people living with mental health issues. And I think police, it would be particularly important because, unfortunately, often police end up being, sent out with ambulance crews, to people who are really just struggling with a mental health crisis, and so it's kind of one of those things that's just there's a vital need, obviously in inpatient as well, but in those areas, I think definitely, because many people with mental health issues, either already live with trauma or for various reasons are at much more risk of developing trauma if they're not treated with an appropriate level of care, respect, and there's a striving to maintain dignity. I think that's my thought.
Yeah, no, it's lovely. Can I, did you want to share very quickly the work that Being is doing in this space to help, if that would be appropriate?
In terms of sort of getting people involved in advocacy? I mean, one of the core, as I said earlier, one of the core things that Being does really is we try to be a bridge, between consumers on the ground experience and, the policy processes that end up producing services and legislation. And to do that, I mean, you'll find that we do a lot of advertising, to get people involved in things like consultations, co-design processes, and even to be on committees in government. So this is kind of a way that people can step forward if they're interested in, kind of moving more into that kind of world of systemic advocacy. We really sort of need to talk with people on the ground all the time, or else we don't really go to government with a voice that reflects what people's needs really are. So I'd say, keep an eye out for things like Mad Monday Memo and for our social media for opportunities to be involved and to get involved.
It's lovely. Thanks, Peter. Right, I'd like, and again, this is some suggestions some questions for all of you. Look, there's been lots of amazing things that you've raised in this beautiful conversation around the Act, about being seen as humans, some magic about the documentation versus implementation, the state of legal services, what good looks like from nurses. There's a lot. It's just a big conversation. I want to focus on the positives and what we can do practically. So I'm wondering if each of you could share with everyone that's viewing in today, just some practical things that you would like to see happen, that we can move towards these aspirations and support consumers better. And let's start with you. What are your recommendations on?
Well,
what are we going to do to fix all this stuff?
I wish I had that magic wand. One thing that's very big in public health at the moment is co-design. So the idea being that facilities or policies or processes are done in not just in consultation with, but active, engagement with the people for whom the service is going to provide care. Part of the difficulty with that is getting people to respond. Co-design, people, particularly those who've had experience with mental health services, are worried about going on into where they might be the only consumer in the room. But it's really, really important, and you can make a huge difference. If you're concerned about this, you want to get engaged with your concern, take a friend. Make sure there's more than one of you. It's a bit safer that way. You feel safer. You feel more able to, say what you think. Listen first, though. Listen, hear what they're saying, get your argument together, and then, maybe challenge some of the stuff that's going and being said. For some services, they're genuinely developed co-design processes. Other services, it's, well, we wrote it, we'll ask, the consumers have seen it. Didn't necessarily agree with it, but they've seen it, so we've done co-design. So it's important to understand what co-design actually is and means, and to get engaged and go out there and be engaged. Don't always let carers or the people who, there are, you don't want to stop people who care, and you don't want to stop the people in the community who are interested and want to promote things, but you do need to have your voice, because there's 3 guys on this panel with me, not one of them can describe childbirth, and so it's the same sort of thing with that lived experience of hospitalisation, of being treated for mental illness or whatever. You need people who actually understand what that means and what the impact is, and look for opportunities. As Peter was saying, Mad Monday, if you're in a rural or regional area, keep your ear to the ground, see if there are consultation going on, and get involved. But do stay safe, do take a friend, do make sure you feel comfortable with it, because it can be very challenging when you're up against, when you've got a whole lot of professionals in the room, often speaking in a language that you're not familiar with, because they use all sorts of acronyms and things. Don't be afraid to pull them up. Ask them, what does that mean? Because they actually forget that the rest of the world doesn't speak that way. So
that's really sage advice. And I think, things like, bring a friend. I think, there's just very practical things. I love what you said about co-design as well. And I work with other organizations in different parts of the not-for-profit sector. And there's another term, assets-based community development, where you look at the assets. And I think this is one thing that, your sector does brilliantly, that Being does brilliantly. So thank you, Anne. Now, you mentioned that you didn't have the magic wand, but I think Butch has been talking magic, for a little while. So I just wondering, Butch, I think maybe if you've got a handle on the magic wand, yeah? Do you want to give us
No,
not at all.
I think if you want to be a peer worker, I think you've got to be the magic, and that really interpret, to me, be careful the peer job you choose. Think wisely about what part of mental health you want to work in. A lot of people say, I would love to be an inpatient advocate. I can tell you it's a really tough gig. You don't have other advocates with you in that situation. You're on your own a lot. You've got to have an amount of resilience. You've got to have a really close look at the part of the workforce you want to work in. And it's like that song, The Gambler. You've got to know when to hold them, when to fold them, when to walk away, and when to run. So with all great intentions, we all want to advocate, even nurses do too. But sometimes you've got to sit on your hands, and that can be a hard thing to learn. So that systemic advocacy quite often can cut in, like Peter said, the bigger picture. You could go with greatest intention to help an individual, whether it's a family member or whether you're in an advocacy role. Choose your battles sometimes. I think it's really good wisdom that come from clinicians a long time ago. Pick your battles and look after you no matter what you're doing for a living. If you're not working right now, make it fun. Make life a bit more fun. I think we've got a better future in front of us. I think we're starting to modernize a little bit and having these healthy discussions. But looking after you is the important part. And like I said earlier, if you can possibly dance once a week and enjoy your day, that matters a whole lot.
Yeah, that's lovely. And I think Robin said sort of similar things in the session last week about, what did she say? Just pick your lane, pick your passion, same sort of thing. Move forward, do what you can, and keep it moving. So, yeah, thanks, Butch. Good advice. Peter, your thoughts on suggestions that you have for people to become involved in either systemic or individual advocacy. What can we do?
Well, I suppose becoming involved in either would be great, but I think it's really good to ask yourself at the beginning, whether you'd prefer to work with individuals or whether you'd prefer to work in, things like government processes and meetings, because they're kind of both fairly different experiences of what it is to be an advocate. And I mean, they're both vitally necessary because we get lots of calls from people who are struggling to find their way through the mental health system. So goodness knows we could do with more peer worker advocates, basically, to help people navigate the system, and not just in inpatient, I'd say, either, but also, the broader mental health system. And I think peer workers are a kind of potential, have this potential to be a part of the system which keeps people out of hospital. That's my view. I mean, in terms of systemic advocacy, as I say, keep an eye out. But there's also some other initiatives Being is progressing at the moment, like the Being Leadership Academy, where we're providing various courses to provide training and support to people as well, in terms of, becoming advocates and participating in committees and things like that. So it's also good maybe to keep an eye over the next year or so on the work that we're progressing, because it's definitely a goal of Beings to kind of, build the organisation to be as supportive as possible of people who are wishing, to become systemic advocates, I'd say, and also supporting people who want to sort of get involved in individual advocacy as peer workers too.
That's great. Thanks, Peter. Now, I would like to sort of open it up to the audience for some questions. So if you've got some questions, please pop them into the live chat. Now, we have one from Leanne. And Leanne's question is, how do we advocate for marginalised populations like street people who are living with mental illness with no access to appropriate services?
I'd love to have a crack
See your
at
hand
that.
coming up there, Butch. Will you grab this one?
I was homeless twice, and I think Peter nailed it earlier when take the time to hear people's stories is the important part. So storytelling, and just it doesn't matter who you are and what position you're in, but take the time to talk to people who are on the streets and hear their story, because you can't help people if you don't know what their situation is at that time. And it's a wonderful thing if you feel safe enough and sometimes even brave enough to just have that open discussion with a stranger about their story, and that means you're going to have to share some of yours. So be brave. Yeah.
Thanks, Butch. Thanks, Butch.
I think, and can I just say there's a point there, Omar, sorry.
Yeah,
Butch said you have to share some of yours. If you're going to do that, if you're going to share your story, think about it. Don't just blurt out. Think about what you want to share and what you don't want to share. Because once you've told it, it's out there and you can't take it back. So be very, think really constructively about, and I know this is hard for people because they do want to share, but the point of sharing your story is to give that other person comfort and knowledge that they're not on their own, that others share similar experiences. It's not to dump everything on that person, because then that's not a help. But you also need to be very clear about what parts of your story you want to share, because sometimes things are very private, and once they get out there, they're gone. So do think about that if you're wanting to get involved in advocacy, wanting to support other people. Do protect yourself that way.
Great advice to all of you. All right, now we're going to go to David's question and sort of shift the tangent a little bit here with a great question. David says, this webinar is largely focused on hospitalizations. Are there any suggestions for advocating with GPs when on our own?
Oh, absolutely. I know Grand Pacific Health Medicare local model and some other organisations have a GP model where they take assertive action there, and outside of the hospital, obviously there's community treatment orders where GPs themselves can play a big part in community treatment orders where there's no mental health facility. So there's advocacy and there's different things that take place, definitely, and they certainly need to improve. And I would go back to our modern peer workforce that we need to have that advocacy model come back into our modern peer workforce, because that's been neglected for some time.
Yeah, I think the question is really about suggestions for advocating with GPs when you're on your own. And that's really challenging, because people do, the GP, well, anybody, any medical person has a level of authority and knowledge, professional knowledge. But that doesn't necessarily align with your experience of your health. And it doesn't just apply to mental health, it applies to other things as well. I think things like, be aware of what you want to say, be aware about what you want to talk about, where you want to go with it. Take notes, with you. Write it down and tick off the list. You're paying to be there, do it.
Now, I want to. We've got probably 5 more minutes. I just want to come back to, I think, some of the areas we were chatting about before on the panel that are of kind of interest to you individually. Just wondering, I'll go to each of you just for a quick 30 seconds, 40 seconds, kind of final word, final wrap up from your side, Peter. Is there anything more you want to chat about the recognition of those that use mental health services that will have experienced some form of trauma?
I don't know. Firstly, I can't help. I have to say something about GPs. I'm sorry as well.
Say something about GPs. Go on.
Yeah. GPs are hard because, there are some GPs who are very aware of and interested in mental health, and there are others who aren't, so I think it's also partially about finding the right GP. It's a bit like looking for the right therapist. It's a bit of a fit thing as well, and at the very least, depending on what you want to get, if you want a referral, maybe that's all you need. Oh, here's a referral to a therapist. But so I'll throw that in quickly. I think it's interesting because, again, in terms of mental health literacy, GPs really probably have quite a bit to learn in a systemic sense, even though individually some GPs are great. But there was one other issue I thought I'd flag, which was the importance in terms of health rights for people who live with mental health issues of, recognizing physical health issues as well, and not overstating or understating people's, mental health issues at the expense of, addressing people's physical health issues. So, and this is something that impacts, it's certainly not just people at the pointy end of the spectrum. It's pretty much everyone who's taking, antidepressants or anti-anxiety meds, or, and antipsychotics, obviously, as well, because a lot of these medications have a lot of physical impacts. So I think it's a really important issue as well at the moment, that we need to kind of make that alive. GPs are kind of part of the solution to that too, I think.
Well,
sorry, I talked too much.
No, all good. We've got like a minute and a half. And very last quick word from you on any aspect, final word, or is there anything you want to share on trauma-informed care, or give us a final wrap-up?
Well, I know that there's been the Agency for Clinical Innovation Mental Health Network was developing a clinical guideline for trauma-informed care for mental health clinicians. Now, I'm not sure where that's got up to now, but it is incredibly important to hear, as Peter said earlier, hearing people's stories. Hearing their story and their understanding of their story, not your perception of their story, will go a long way to giving that person identity, reality, and, helping them move forward in their lives. There's so much more to say.
I know. Let's jump to Butch. Butch, you've got 10 seconds. Tell us about the future of what you want our children to see. Come on.
Be proactive, not reactive. Change equals change, and own your own destiny a bit more. There's a lot more to life than just mental health services, and channel your energies and just be seeing and doing and live life to the full. And if you want to play a part with mental health, we'll embrace all of you.
What a brilliant way to wrap up. Listen, I want to thank all of you. Brilliant, fantastic session. It's been so interesting. Thank you also to our wonderful audience. Thank you to Being, who's here to amplify the voice of lived experience. We've got the recording will be ready shortly. We've got another session next week, Thursday, 11 a.m. on peer support, peer work. And I want to leave you all with one final call to action. And that is, we hope that in Robinson's, we expect that we as consumers can advocate for and influence systemic change. We ask the government to sit up and act on what consumers have to say. We ask decision makers to listen to the insights of our speakers on how we can improve our systems and infrastructure to support the human rights of people who live with mental health issues. We ask that our advocacy voices are heard. Thank you. Thank you. We'll see you next week, 11 o'clock, where we'll be exploring peer work. Thank you so much. What a great panel. And thanks for being. See you next week.
Thank you. Bye.